From theheart.org, Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Stephen and Suzanne Weiss Dean of Weill Cornell Medicine and Provost for Medical Affairs of Cornell University. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, I'm Bob Harrington from Weill Cornell Medicine in New York City, and I'm here at the Heart Association Scientific Sessions in New Orleans. It's been a great meeting, and a lot of the science that's presented is not just on heart health, which is what you think about at the American Heart, but you also have to remember that the Heart Association is the American Stroke Association as well. So there's a lot of science here on stroke, on cerebral vascular disease. And what's pretty apparent as you walk around to the sessions or you look at the posters, that there's this intersection between heart health and brain health. In fact, one of the comments I've heard in several sessions that I've been at over the last couple of days is heart health is brain health and brain health is heart health. So I thought we'd use the time here in New Orleans to talk to one of my colleagues who is a neurologist and who's playing a leading role for the American Heart Association in understanding brain health. So I'm really pleased to be joined by my good friend and colleague, Dr. Mitch Elkind. Mitch, thanks for joining us here on Medscape Cardiology and theheart.org.
Well, thank you, Bob, for having me. I really appreciate it.
Mitch is the Chief Science Officer for Brain Health and Stroke for the Heart Association. That was a new job created as people began to understand this connection.
That's absolutely correct. Yeah, first person to hold that position. I'm really excited about it.
You're also a stroke neurologist, and you are a professor emeritus at Columbia University in New York City.
Absolutely.
And the other thing is that Mitch and I are very close because we served as presidents of the American Heart Association, me and then you.
That's right. I followed in your footsteps.
And we had a great time during those couple of years, despite the toughness of the time, which was COVID.
Exactly, yeah.
So you heard how I opened it up with this notion that heart health is brain health is heart health. And what I'm trying to get at, and what I think as I walked around the sessions talking to people, they mean that the risk factors, hypertension, smoking, bad diets, lack of physical activity, diabetes, obesity, all of the things we think about as life's essential 8 for the heart, it's also life's essential 8 for the brain.
We certainly say that what's good for the heart is good for the brain, but I think it is really important for people to remember that what's good for the brain is also good for the heart. It is a two-way street between them.
I didn't say that you were just the stroke science officer. It is brain health. The AHA is doing things other than just stroke care.
Well, we're trying to now. That's right. So we're kind of launching a new initiative around brain health. So we've always done stroke, pretty much throughout the entire history of the Heart Association. But now we're beginning to go beyond stroke to conditions that we know are connected to the vascular system in the heart. So things like cognitive aging and dementia. We know the same risk factors for heart disease and stroke are also risk factors for dementia, for example. But there's other connections between the blood vessels and brain disorders. Think about migraine, which is also a risk factor for stroke, may even be a risk factor for heart disease. Some research suggests.
You mean more than like atrial septal defects and the risk of stroke in people with atrial septal defects have some increased risk of migraines?
Yeah, well, the mechanisms are not entirely clear for how migraine may contribute to heart disease per se, but we do see in observational studies an increased risk of cardiac events as well in people with migraine. It could be, differences in behavior due to the migraine, could be other things too, confounding factors, but there seems to be an association that we need to tease out with further research. Things like epilepsy, the leading cause of epilepsy in adults is really cardiovascular disease and stroke, sometimes even silent or microinfarcts. So that's a condition that, overlaps as well.
That we might not initially think about.
Exactly. And frankly, even things like traumatic brain injury, an injury to the brain, whether it's a stroke or traumatic injury, may lead to similar kinds of secondary effects. The accelerated neurodegeneration that we are beginning to see or recognize in stroke patients seems to also happen after traumatic brain injury. So there's a lot of overlap there.
When we think about some of the neurodegenerative diseases, you started mentioning it, things like Parkinson's, is there a connection with the heart?
Well, there's certainly a connection with the vascular system. Parkinson's, I think the story may be a little bit different. So one of the interesting things is that one of the earliest manifestations of Parkinson's is actually degeneration of the nerves that are affecting the heart, the autonomic nervous system to the heart. We think of Parkinson's as causing tremor, but
Right.
it also causes autonomic degeneration, right? And so one of the earliest things you can pick up is abnormalities in innervation of the heart. So there's a connection there, but I think that's better worked out or further advanced in the study of Alzheimer's disease, for example, which is more common than Parkinson's.
Well, let's talk about Alzheimer's, because you mentioned, you very specifically, I think, said cognitive decline.
Mhm.
You didn't say Alzheimer's.
Mhm.
You're not making them the same.
Well, they're really not the same because very few people, if you look pathologically after they die, do you find only Alzheimer's disease. Maybe 5% or so will have only Alzheimer's disease. Most of the time, in somebody who dies with dementia, you'll discover the pathology of Alzheimer's. You'll discover small infarcts or
Yep.
large infarcts. You'll see Lewy bodies and other types of misfolded proteins and so forth. Maybe degeneration from alcohol or other toxins. So most of the time, dementia is caused by an overlap of different conditions. So it's hard sometimes to tease out the specific pathology that's causing it. But to the extent that we can, yeah, it seems like the vascular risk factors contribute to the Alzheimer's component of it.
And as we think about, Life's Essential 8 and the risk factors for heart disease, particularly coronary heart disease, and we think about things like diabetes on the brain.
Diabetes is a risk factor for small vessel disease, certainly. Just, I think you probably see that in the heart.
We
and
do.
We see that in the brain to a large extent. And we know that small vessel disease of the brain can be an important contributor to dementia. Probably the biggest risk factor, though, is high blood pressure,
Right.
which also causes small vessel disease. And you're probably aware that in the most recent guidelines for the prevention and management of hypertension that came out from the American Heart Association and the American College of Cardiology, joint guideline came out in August of this year. For the very first time, they give the highest level of evidence to treatment of blood pressure to prevent cognitive decline in dementia.
Yeah, that was an important observation that they put out there, and it sort of made highlights on the news.
Yeah, it's gotten a lot of attention, and it's based on high-level clinical trial evidence. So that, I think, is the first kind of definitive proof of how treating a vascular risk factor can mitigate cognitive decline in dementia.
Now, one of the areas in cardiovascular medicine that has gotten so much attention over the last couple of years is obesity and the treatment thereof, and in particular with the GLPs and associated other agents. Not only losing weight, but markedly reducing cardiovascular risk. And do we see the same with the brain?
Well, we don't have any trials that have focused solely on that or, as a primary outcome, but in secondary analyses of the cardiovascular data, there is suggestion of that as well. Certainly stroke and just beginning to emerge data around dementia as well. But we need dedicated trials, I think, to show.
And are we going to have them? Do you know if they're being planned?
I don't know that there's any that's, already on the way, but I certainly think it needs to be done. Neurology tends to follow by about 10, 15 years behind cardiology.
You and I have talked about this.
Yes. So I'm sure
The
we will be
fibrillation
getting
story is a good example of this, right?
Yep. All of these things, and it just stands to reason. And another major risk factor, of course, is atrial fibrillation, which can cause strokes, but there seems to be a connection between AFib and dementia, sometimes even outside of people having clinical strokes, which suggests that subclinical or small infarcts may also play a role. Of course, with AFib, you also have a decrement in perfusion to some extent, so that may play a role. And the same kind of phenomenon, I think, exists in heart failure, where patients with heart failure have perhaps a 30 to 40%, at least advanced heart failure, 30-40% reduction in perfusion of the brain. So we do see cognitive problems in patients with severe heart failure.
This morning I was at a session on the metabolic abnormalities around atrial fibrillation. There was a state-of-the-art talk given, and I asked the question, you have all the modifiable risk factors lined up, the things we've just talked about, Life Essential 8. I said, if you were to concentrate on one, just one, what would you concentrate on to lower the risk of atrial fibrillation? He said, weight loss. He said, weight loss ties to other things. He said, but you get such a profound benefit of reducing the risk of atrial fibrillation with weight loss. He said, that's where you need to go first. Now, it pulls along other things like diabetes, et cetera. But how about for the brain? If because our patients, as we're trying to counsel them, talk to them, you can't focus on everything, at least at the first sort of setting out on this journey together. Is weight loss the most important for brain health?
I think most people would say no, not that it's not important.
They'd say hypertension.
They'd say hypertension, and probably as far as behavioral factors go, it's going to be exercise. I mean, there's a fairly robust evidence base about the benefits of exercise for brain health. Again, it's hard sometimes to prove these in the kinds of randomized large-scale trials that you do, but exercise and exercise too has so many benefits on blood pressure, on
on atrial fibrillation,
weight, on AFib as well. The other major one, frankly, is sleep, right? So we know that to some extent, clearing the brain of amyloid and other toxins is dependent on the glymphatic system, right? So that's your body, your brain's way of clearing toxins, just like the lymphatic system in the peripheral body. And so getting adequate sleep is what allows that system to function. It only works when you're sleeping and certain stages of sleep.
So it has to be not just sleep, but quality of sleep.
It's the quality of sleep. It's really interesting because it depends on you sleeping and having the right sleep stages, but also cardiac function is kind of a passive system. And so the heart has to pump adequately for the lymphatic system to work. And so it's a real great example, frankly, of that connection between the heart and the brain.
We were talking about GLPs, the connection between the heart and the brain, or maybe the gut and the brain with regard to the GLPs. Want to pull that into it?
I think the GLPs are really interesting because we think of them as this metabolic, gut enzyme and so forth, but we've been seeing effects on the brain in terms of substance abuse, right? Gambling, addiction. And so, I think of them as a neurologic drug. And so I think, and there are small studies that have suggested this, but I think, again, we're going to need more data and larger scale trials to demonstrate that. And whether those are going to happen or not, there may be concerns about making those tests because people don't necessarily want to get into certain areas with those drugs. But I think those studies do need to be done, not just for, strokes and dementia, but for other neurological and potentially even mental health disorders.
The list keeps growing every month or so. When you go to a meeting, you look at effects of the GLP-1s and it's like, whoa. Where that would show up from. So you were brought to the AHA after a really successful career at Columbia as an academic stroke neurologist. You've been a long-time AHA volunteer. You've wanted to passionately get the AHA engaged in brain health. Give us a sense when we say the AHA is getting involved in brain health, what that actually means.
So
without giving us any secret information
right. Well, so, as we've been talking about, there's a connection between the heart and the brain, but I think, we've always really focused on that heart piece of it. What's good for the heart's good for the brain. And so any benefits that the brain may accrue from taking care of the heart are sort of like gravy. That's a nice thing to have. But
gravy's probably not a good thing to have, particularly here in New Orleans.
Right, that's true. But there are really interesting ways, of course, in which the brain also has benefits for the heart. I mean, as you say, we're sitting here in New Orleans where there's an interest in voodoo. And for many years, of course, we've known about the syndrome of voodoo death. Right? And what is the cause of voodoo death? You're literally scaring someone to death. You're affecting the brain, which is the presumed mechanism is you're affecting the brain, which leads to an extreme sympathetic output that puts strain on the heart. And that can lead to something like Takotsubo cardiomyopathy, where the heart doesn't pump normally without ischemic disease, or at its worst, extreme, sudden
cardiac death.
Sudden cardiac death. So there's like a great example of how the brain can influence the heart as well. And there are others too. I mean, you talk about the various risk factors. There are, let's say, brain-related risk factors for heart disease too. I'm thinking about things like depression, anxiety, loneliness, social isolation, and these
those
kinds
are risk
of
factors for myocardial infarction.
Exactly. And currently they're not actually in, let's say, Life's Essential 8, which is our easy to remember tool for people to cut down on their risk factors. And the reason for that is simply there hasn't been enough enough evidence on those benefits. But I could imagine in the near future we'll be including those kinds of risk factors in our tools for assessing risk and helping people cut down their risk. And so those are the kinds of things that I envision us doing. There's a growth in this area of brain health right now. Every neurological society has a brain health initiative within the last couple of years, which is super exciting. There are things that we can do for brain health that we never had available in the past. So there's reasonably a lot of excitement around brain health. But I think what the Heart Association can really offer here is that connection to the heart and, frankly, the rest of the body. The Heart Association has gotten more and more interested in the cardiovascular, kidney, metabolic syndrome. That basically includes everything in the body except for the brain. So I think we'll be putting the brain back into that equation
getting it
as
back
well,
together.
and thinking holistically about health.
One of the things that the AHA is so good at is thinking about what are new therapies, what are new approaches, how do you take clinical trials evidence and get it implemented into practice. We clearly need more clinical trials. What kind of clinical trials? What are the things that you would study, either from a strategy perspective or a medical intervention perspective that might improve brain health, that we don't have enough data, but we have a hypothesis?
So there are a couple of areas that I would highlight there, and we're beginning to take steps in both of them. One is this question of how a stroke might ultimately lead to cognitive decline and dementia. So if you think about the traditional idea of stroke, the thought is that, let's say you go through life at a certain level of function, you have a stroke, you lose certain functions, become paralyzed or lose the ability to speak. And almost everybody, if they don't die from a fatal stroke, they recover from the stroke to some new baseline level of function. And then we think, okay, and then you go through life at that level until you have another stroke. But in fact, what we see in observational human studies as well as animal studies is that people actually decline at a certain point after a stroke. Maybe not everybody, but a good chunk of patients decline, and we all decline obviously over time, but we see an accelerated decline in people who've had a stroke. So the hypothesis is that having had a stroke, that damage to the brain actually sets up a chronic condition whereby there's accelerated neurodegeneration, breakdown of a blood-brain barrier, perhaps neuroinflammation. And so several of us are interested in this idea that using an immune therapy or an anti-inflammatory therapy might help to mitigate that secondary delayed cognitive impairment and neurodegeneration. So that's like a connection between a stroke, which is certainly a vascular condition, and neurodegeneration, if you will.
And that gets at this whole concept that the AHA also talks about, health-adjusted life expectancy. That it's not just how long you live, but to your point, what's the quality of how you live? And how do you quantify that to really understand over the lifespan what actually the benefit of an intervention is?
For sure. And then a second area that I think is, even more up your alley, perhaps, if you think about patients with heart failure, we know from some studies that assessing for mental health disorders like depression, anxiety, and then treating them if present can help to improve outcomes in patients with heart failure. And so when we think about brain health, we're talking not only about neurological disorders where there's structural injury to the brain, but also mental health, behavioral health disorders, which are also, as we said, they're closely tied to heart disease. So one could imagine a study where you look at patients with heart failure, perhaps in our registries, like our Get With the Guidelines registries that have been so effective at, improving the quality of care and reducing disparities. One could also randomize patients, do a pragmatic trial within the registry, a registry-based trial to test the benefit of assessment and treatment for mental health disorders. So that would be another way to bringing the brain back to the
I want to cover in the last couple of minutes two more topics.
Okay.
One of which is that I had an interview a couple of months ago that we posted with Eric Topol about his new book, Superagers. His basic premise is that there are people who live into their 90s with no health problems. And then there's a group of people who live into their 90s, and they had a lot of health problems along the way, but they still made it into their 90s. And he talks about the big three: cancer, heart disease, and neurodegeneration. And one of the things that is he talks about the different type of superages, that there's something about their immune system and their inflammation that links them. You mentioned inflammation. What do we know about inflammation in the brain?
Well, we know that inflammation and neuroimmunity plays an important role in a number of conditions. The sort of paradigmatic one is multiple sclerosis,
Ah,
right?
okay,
That's a
yeah.
neuroimmune condition. But we see neuroimmune mechanisms playing an important role after stroke. As I mentioned, we can see how that leads to long-term decline. And even in primary neurodegenerative diseases like Alzheimer's disease, immunity is increasingly recognized to play an important role there. And there are people doing studies using immune
To
agents
interfere with, yeah.
to interfere with neurodegeneration. We still don't really understand what the primary, problem is in Alzheimer's. There's been a lot of debate back and forth about whether it is amyloid or not. Some people say that it must be amyloid. Could we see some benefits from these new
Yep.
anti-amyloid immunotherapies? And other people say, well, those effects are too modest. The truth is there's probably several different types of
Right.
Alzheimer's disease, depending on what the underlying mutation is or causes are. And as I mentioned, a lot of other things usually contribute to it also. But yes, there seems to be some evidence that immune mechanisms play a role, but we haven't yet proven that treating those will lead to a
So we
benefit.
think it might play a role, but well, we haven't done it. So the hypothesis might be there, but we don't know about interfering with it,
Yeah.
whether or not that helps.
Yeah.
Final topic. The other thing that you've been involved with the last few years with the Heart Association has been food as healthcare, food as medicine.
Mm-hmm.
Food is medicine for the brain. We talk about ultra-processed foods and the deleterious effect it has on us from an obesity perspective. It certainly seems to have an effect on heart disease. What about the brain?
100%. Yeah, no, we are looking at, many other conditions. We haven't yet focused on the brain in our Healthcare by Food initiative, which is all about food as medicine. But we have a trial that's looking at food as medicine approaches after stroke.
Ah,
And it makes sense, right? Because when somebody has a stroke, they may lose the ability to cook, to even shop for
Yeah.
themselves, and they may, have to resort to eating less healthy foods as a result. So stroke, I think, is a great example of where there may be a benefit for food as medicine programs like medically tailored meals, for
Yep.
example, that will take some of those issues about cooking.
so
off the
it's not
table.
so much that they have food for the brain, so to speak, but it's the fact that you are taking into account the disability of stroke.
That's a piece of it. I think that accentuates the benefit, but I think there's also the fact that medically tailored meals, to the extent they will help reduce blood pressure,
Got
could
it.
be of benefit
Yep.
for reducing recurrent stroke. And yes, there is evidence that even for patients with cognitive decline, dementia, that healthy food can be of benefit. There's something called the MIND diet, which is, I think of it as like the Mediterranean diet plus blueberries.
As an antioxidant?
Exactly. Yeah. So it emphasizes that benefit of antioxidants on top of the Mediterranean diet benefits, and that has been shown to have benefits for cognition and dementia.
You are going to have no shortage of things to work on over the next few years.
I'm excited about that.
That's fantastic.
Yeah.
I hope that you can come back as some of these activities get launched, as some of these initiatives get launched, and we can talk more about it. I mean, one of the things that people write into us about is to try to understand more about, healthy living, healthy brain living. And so we'd love to chat more about this.
I look forward to it. Thanks a lot, Bob.
Well, I want to thank you for listening. My guest here today has been Mitch Elkind, who is the Chief Science Officer for Brain Health and Stroke at the American Heart Association. He's also a Professor Emeritus of Neurology at Columbia University. And I want to thank you for listening here on Medscape Cardiology and theheart.org. If you liked it, tell us what you liked about it. If you didn't like the show, give us some suggestions. And if there are people you'd like to see me talk about or talk with, please do leave a comment for us so that we can think about whether or not that'll appeal to our broader audience. So again, Bob Harrington, thanks for listening.